Hello students, I am Dr. Kumar, Assistant Professor in Department of Oral Medicine and Radiology, Vinaya Mission, Sankaracharya Dental College. Today's my topic is Intraoral Radiographic Anatomy. Before that we will go into this topic. The intraoral radiographic anatomy is very important procedure to identify the lesions in the intraoral radiographic films. Okay. Today's my content is actually first one is structure of tooth. Second one is supporting structure of tooth. Third one is anatomical landmarks of mandible. Fourth one is anatomical landmarks of maxilla. These are all the four contents in my class. First, we should know about the normal anatomical landmarks in the radiographs. Then only we should know about that is not a error or that is a lesion. We can confirm and it leads to the diagnosis of the proper lesion. So, you have to know about the first normal anatomical landmarks of the intraoral periapical radiograph. The contents, the structure of the tooth. In this content, first we are going to enamel. The normal enamel, how it appears in the intraoral radiographic view, periapical IOPA. Radio opaque than any other tissue because it is more dense, naturally occurring substance in the body, being 90% of mineralized. It causes a greater attenuation, means stopping of the X-ray photons. So that the enamel is dense radio opaque object, it covering the crown of the tooth. It will appear in the like this. In the end of the crown, there is a thick radio opaque area, that is the enamel. It appears in the radiograph. Then next one is dentin. Dentin is actually 75% mineralized because of the low mineral content. It is roughly compared with the bone and dentin. This is the next to the enamel. Compared to the enamel, the less radio opaque area is called dentin. Dentin is appears this. The below the enamel area, the dentin is appears. Then pulp. Normal teeth is composed of soft tissue and hence the appear radiolucent area. In the center of the tooth, there is a radiolucent area. That means black area. That is called pulp structure in the teeth. In the crown portion, there is a pulp chamber and also the root canals also. It is the radiolucent area. So pulp is the crown portion and root canals also seen. Then cementum. A thin layer of cementum on the root surface as mineral content is about 50% actually compared to the dentin. It is not usually apparent in that radiograph because the contrast between the cementum and dentin is very difficult to differentiate in between that. So because there is both of the structures same mineralized content. So dentin is the same as the radio opaque as the cementum. It is covered only the root surface of the teeth. Then next subheading is the supporting structure of the tooth. The tooth supporting structures are how it appears in the radiographic area. The tooth supporting structures, first one is the lamina dura. The sound teeth is the normal dental arch, demonstrate that the tooth socket is bounded by the radio opaque layer of dense bone, namely the lamina dura. The layer is continuous with the shadow of the cortical bone or the alveolar bone crust. There is immediately adjacent to the tooth surface, there is the arrow mark. It shows the thick radio opaque border around the tooth structure. That is called lamina dura, the radio opaque area. It appears of the lamina dura is a valuable diagnostic feature. The presence of intact lamina dura, the continuous lamina dura of the apex of the tooth strongly suggests a vital pulp. Pulp is vital. If the lamina dura is continuously around the tooth, that means there is no infection. If the lamina dura break or discontinuities appears, something will happen. The inflammation is there in the tooth. That is the one strong valuable diagnostic feature. Lamina dura is an important valuable diagnostic feature. So next one is alveolar crust. The gingival margin of the alveolar process extends between the teeth is apparent on the radiograph as a radio opaque line. The level of the alveolar crust is less than 1.5 centimeter here in this arrow mark. In between the tooth, that is the bone, alveolar bone. The crust is the upper part of the alveolar bone is called alveolar crust. The crust of the alveolar bone continues with the lamina dura and forms the sharp angle with it. The rounding of the sharp junctions is indicative of the periodontal disease. If it is the sharp, it is the sound teeth. If it is a blunt or there is indicates the loss of bone. The alveolar crust is lost. So indicative of the periodontal disease. So next one is the periodontal ligament space. Immediately adjacent to the tooth surface lies the periodontal ligament. It is a soft tissue. is a composite of the soft tissue surrounding the tooth structure. The average width of the periodontal ligament in adult tooth is the function is the 0.18 millimeter. It has an hourglass shape. It is wider in the coronal aspect, slightly narrow in the near the apex. This is the in between the teeth surface and lamina dura. In between that there is a small thin radiolucent line. That is the periodontal ligament space. It is wider in the coronal aspect, slightly narrow the near to the apex of the teeth. In younger patients, the periodontal ligament space is thicker. They become thinner in elderly. Periodontal ligament space is wider when the teeth are mobile or loose. The periodontal ligament appears thicker in the presence of some disease like early malignant disorder such as osteogenic sarcoma or fibrosarcoma. The periodontal ligament space is invisible in the ankylosis. If the trauma will occur, the periodontal ligament space is disappeared. The next one is the trabecular pattern in the mandible. The trabecular pattern in the anterior mandible thicker than the of the maxilla, resulting in chorus pattern. The trabecular plates are fewer than that of the maxilla and oriented more horizontally. Marrow spurs are larger in the mandible. The trabecular pattern in the posterior mandible quite similar to the marrow spurs, somewhat larger. Marrow spurs is only larger in the posterior side. So next, go to mandible. Anatomical landmarks of the mandible. What are all the normal anatomical landmarks seen in the mandibular structure while you are taking the mandible IOPA? These are all the following anatomical landmarks. One is symphysis, genial tubercle, lingual foramen, mental ridge, mental foramen, mandibular canal, Newton canal, mylohyoid ridge, submandibular gland fossa, external oblique ridge, inferior border of mandible, coronoid process. These are all the normal anatomical landmarks seen while taking the IOP in the mandibular area. In the anatomical landmarks of maxilla, intermaxillary suture, anterior nasal spine, nasal fossa, nasal septum, incisive foramen, superior foramina or nasopalatine canal, maxillary sinus, zygomatic process or arch, coronoid process of the mandible. These are all the anatomical structure seen in the maxilla. So you can see first there is a mandible, the genial tubercle. The genial tubercle appears during the anterior part of the mandible. In the anterior part of the mandible, it appears as a radiopaque mass below the roots of the incisors, central incisors, below the roots of the central incisors. In the lingual side, it is a small projection. The attachment of the genioglossus and geniohyoid muscles, the two muscles are attached in this genial tubercle. It is a radiopaque object. This is the one normal anatomy. Next is the mental ridge. It appears as the two radiopaque line. See that? Two radiopaque line sweeping bilaterally from the premolar area forward and upwards towards the midline. Forward and upwards towards the midline. It's almost triangular shape, sweeping bilaterally from the start with the premolar to the central incisors. See, that is the two radiopaque area. That is the mental ridge. Then internal oblique ridge. The mylohyoid ridge seen on the lingual surface of the mandibular body extend from the third molar to the lower border of the mandible in this area, in the region of the chin. It serves as an attachment of the mylohyoid muscles. There is a mylohyoid ridge is because there is a attachment of the mylohyoid muscles is attached here. The next, external oblique ridge. The external oblique ridge is a continuation of the anterior border of the mandibular ramus. See that? This is the anterior border, ramus of the mandible. It is a continuation process of the anterior border of the mandibular ramus. This is the external oblique ridge. The ridge is line of the attachment of the buccinator's muscle. The buccinator muscles are attached in the external oblique ridge. Next, lower border of the mandible. Sometimes, occasionally, the lower border of the mandible is seen in the radiograph. Occasionally seen in the periapical projection. In the broad radiopaque border of the bone, the lower border is visible. Next is the lingual foramen. When the genial tubercle seen on the periapical film, it is often possible to see the lingual foramen. The lingual foramen is present in the here. This is a small round radiolucent area. It's by its cortical wall. The foramen contains the termination of the incisive branch of mandibular canal, the termination of the mandibular nerves and vessels. Here it will be emerges. So the lingual foramen, small radiolucent area. Then mental foramen. Mental foramen usually in the anterior limit of the inferior dental canal. It apparent in the apparent radiographs. It is actually seen in between the first and second premolar, below the roots of the first and second premolar. It will appears as a small round radiolucent area. It is often confused with a periapical cyst. Sometimes it's a periapical cyst appear. It is often very difficult to differentiate in the between the mental foramen and periapical cyst in the premolar area. So you have to very carefully differentiate between the mental foramen and periapical cyst in the lower mandibular premolar area. So next, mandibular canal. The mandibular canal is a tube-like passage. It's a tube-like structure. The border is actually radiopaque. In between the two radiopaque line, there is a radiolucent area. The traverse length of the canal extends from the mandibular canal to the mental foramen. Radiolucent band with thin radiopaque line that represent the cortical wall of the canal. It may appear below or superimposed on the mandibular molar teeth. It often is present in the below the mandibular teeth. The inferior alveolar nerves and arteries are passing through the mandibular canal. The anterior end of the mandibular canal is the mental foramen. So next, submandibular gland fossa. On the lingual surface of mandibular body, immediately below the mylohyoid ridge, in the molar area, there is a frequent depression of the bone. The concavity of accommodates the submandibular gland. In this radiolucent area, usually the submandibular gland will accommodate in this area. The radiographic image of fossa is shortly limited superiorly by the mylohyoid ridge and inferiorly limited by the lower part of the mandible. It's below the mandibular area. It appears as the radiolucent area. Then anatomical landmarks of maxilla. So far we have completed the mandibular anatomical structure. So we should know about the normal anatomical landmarks in the mandible, how it appears in the intraoral periapical view. Then go for maxilla. In the maxilla, we have seen in the intermaxillary suture, anterior nasal spine, nasal fossa, nasal septum, incisive foramen, superior foramen or nasopalatine canal, maxillary sinus, zygomatic process and coronary process. Let me see how it appears in the maxilla. First is the anterior nasal spine. Here in this radiograph, mostly seen in the IOP of the maxillary central incisors, located in the midline 1.5 to 2 centimeter above the alveolar crest. Here 1.5 to 2 centimeter above the alveolar crest. It is the thick radiopaque area and usually in the V-shaped, shape is V-shaped. This is the anterior nasal spine, usually in between the maxillary to central incisors. Here it's the anterior nasal spine is, this one is the anterior nasal spine. The next one is the nasal septum and nasal fossa. Nasal septum is the C, the above the anterior nasal spine, there is the radiopaque area. There is a marked as a C, that is a nasal septum. In either side of the nasal septum, there is a two small radiolucent area, the marked as a D, that is the nasal fossa. So this is the nasal fossa and center part is the nasal septum. So here, next one is the zygomatic process. Zygomatic process, it is usually appears as the U-shaped or V-shaped. Here, the U-shaped or V-shaped thick radiopaque line with the rounding ends projected in the apical region of the first and second molars. Usually the maxillary molar, above the maxillary molar, apical to the maxillary molar, there is a two structures. Okay, the thick U-shaped radiopaque line is zygomatic process. There is another one line. It's not a, it's the maxillary sinus. It's often confused with the maxillary sinus. So maxillary sinus is thin radiopaque line. This is the thick radiopaque V-shaped radiopaque line. This is the zygomatic process. The coronoid process of the mandible. Only one mandibular structure, that is coronoid process of the mandible, sometimes appears in the maxillary molar films as a triangular opaque area, radiopaque small triangular area located in the region of distal to the maxillary tuberosity or maxillary third molar. Here, this is the maxillary first, second, third molar. Beyond the third molar and opposite to the tuberosity, there is a triangle shaped radiopaque area. That is a coronoid process of the mandible. That is the only mandibular structure seen in the maxillary radiographs. Then tuberosity, maxillary tuberosity. Maxillary tuberosity is the convex digital inferior border of maxilla, curving upward from the alveolar process and distal to the third molar. Here is the third molar. Distal to the third molar, the curved round shaped bone, the radiopaque area, that is called maxillary tuberosity. An extension of the maxillary sinus is occasionally seen within the maxillary tuberosity. So next, intermaxillary suture. It is called, otherwise called also median suture. In the IOPA, it appears as a thin radiolucent line in between the two central incisors. This is the nasal septum. In between the two central incisors, the small radiolucent line. This is the called intermaxillary suture. In this picture, small radiolucent line in between the two maxillary central incisors. This is called maxillary suture, intermaxillary suture. Then incisive foramen. It is also called nasopalatine or anterior palatine foramen. It is the oral terminatus of the nasopalatine canal. It transmits the nasopalatine vessels and nerves. It often is seen in between the two central incisors in the larger area. It is through the incisive foramen, the nasopalatine vessels and nerves are passing through that. It lies midline of the palate beyond the central incisor at the junction of the median palatine and incisive sutures. It is frequently the potential site of cyst formation. Usually the potential site for the cyst formation. So next one is the maxillary sinus. Maxillary sinus is an important structure, very very important structure seen in the maxillary posterior area. In the IOP of the maxillary posterior area, it's seen in the thin radiopaque line. See in the side, thin radiopaque line is called maxillary sinus. The air containing cavity, it's a radiolucent appearance. Here is some thick radiopaque and the B or U shape is the maxillary zygomatic arch. Often confused with the zygomatic arch and maxillary sinus. Okay, we have to differentiate in between them. In the IOPA, maxillary sinus appears as a thin, delicate radiopaque line. It extends from the distal aspect of the canine to the posterior wall of the maxilla, above the tuberosity. From the canine to the second molar, approximately in the area above the apex of the root, it's seen. Maxillary sinus is visible. This is the some of the all the normal anatomical landmarks of all the teacher. The upper anteriors, the maxillary anteriors. There is a nasal septum, nasal fossa, anterior nasal spine. These are all the structures seen in the maxillary anterior region. The maxillary premolar region. Here, actually maxillary sinus. See that? Here, the maxillary molar region, the maxillary sinus also seen. Here, after the distal to the second molar, third molar, there is a maxillary tuberosity also there. Okay. In the mandibular structure, in the mandibular anterior, there is a lingual foramen or incisive foramen seen in that. Mandibular premolar region, there is a mental foramen is seen in this mandibular foramen. In the posterior side, these are all the normal anatomical structure of the maxilla. So once we know about the normal anatomical landmarks of maxilla mandible, then only we can differentiate between the lesion and the normal anatomy. We are not confused. The diagnostic purpose, the valuable tool. Thank you for watching my class.